Pre-suit analysis on the injuries, on the complaints that our clients are having following a crash or following a fall will help change the trajectory of that case. We can use those before and after pictures to help advocate for our clients so that we can point out exactly what's new. What did this crash cause? Understanding imaging, not just what it can be used for, but also what it can't be used for, is incredibly helpful in pushing forward the argument. The said injuries can be incredibly serious and require lifelong care, yet the MRI will be completely negative. If we can't grasp these medical concepts, we can't ever imagine that we're going to be able to get a jury to grasp them. Finding a way to connect with jurors to make this stuff interesting is the difference between a verdict that's full and fair and one that just doesn't make sense. My name is Matt Grossman. I'm a trial attorney here at Morgan & Morgan. Anybody who really is able to grasp this information, they'll make themselves better advocates for their clients, and they'll be able to see better recoveries overall.
Personal injury cases hinge on the details. ABC Legal, America's most trusted process server, simplifies every aspect of service, so you can focus on winning your clients' cases. ABC Legal-empowered process servers deliver documents nationwide and make 12 million attempts annually, with real-time GPS-tracked updates and proof available online. ABC Legal's simple and transparent services make life easy for your team and help you keep costs under control. Your clients deserve consistent, reliable, and accountable service of process. Sign up for a free account today.
My name is Matt Grossman. I'm a trial attorney here at Morgan & Morgan. I'm licensed in Georgia, Florida, Alabama, and Tennessee. I supervise a team of lawyers who work on trucking cases and catastrophic injury cases throughout the Southeast. I became a lawyer to help people. It's really as simple as it is. This job allows me to change people's lives for the better after they've been involved in something that's unimaginable and terrible. I've focused on plaintiff personal injury work. It's all I've really ever done. It allows me to make a big impact on people's lives, especially when they've been involved in something that wasn't their fault, that's changed the course of their future. The decision to join Morgan & Morgan was simple. There's no other firm in the country that has the resources and the talent that Morgan & Morgan has. We've got the ability to go up against any defendant, no matter how big, and we also have the talent of different lawyers with different specialties to be able to consult with and talk to be able to best handle our clients' cases, no matter what those cases involve. What I'm going to be talking about today is really the medicine, what's involved in these cases from an injury standpoint. I learned very early on that understanding the medicine, understanding the types of injuries our clients are dealing with, the types of procedures they're involved in, the types of imaging that they're having to go through, understanding that changes the entire trajectory of their cases. To be able to really grasp what they're going through and grasp the traumatic nature of their injuries, it allows us to better communicate with the client, especially early on. So during the life of the case, they feel more confident that their lawyer not only is advocating for them, but understands what they're going through. It also allows us to better communicate with our clients. A lot of times they're going from doctor appointment to doctor appointment, and they're not really understanding exactly what the doctors are telling them. So they turn to the lawyer. They turn to us to help better explain to them exactly what their findings are. Because a lot of times the lawyer is spending more time with that client discussing with them what their MRIs may show, or discussing with them why they're feeling the way that they're feeling, more so than even their doctor is. Pre-suit analysis on the injuries, on the complaints that our clients are having following a crash or following a fall, will help change the trajectory of that case. The reason is because, one, we typically spend more time talking to our clients in that consultation, in that first conversation, than the doctor will at their first visit. And so understanding what our clients' complaints are will help guide them in how to best articulate that to their doctors. Understanding the medicine, understanding the injuries, the diagnostic imaging that's done, being able to point them back to those things really helps to change the case, helps to better put the case in a light that not only to the defendant's experts, but also eventually to the jury. To be able to take the medicine, to be able to take the injuries and all of the findings that support our case And being able to sum that down to better articulate that to a jury helps get our clients the results they deserve. So the objective in this presentation is to help take the common medical terminology, the common procedures that we're seeing, and both be able to better understand it and also be able to better advocate for those injuries when we're going up against whether it's insurance adjusters, defense attorneys, defense experts, or eventually putting that case in front of a jury. The three topics that I want to focus on today are, one, the anatomy in the films and understanding what we're looking at. Two, the injuries, the testing, and the procedures that we commonly see in these types of cases. And finally, the common defense arguments that we see over and over and over again, and how to overcome those arguments. So, anatomy and films, we're gonna focus on the spine, the brain, and the different types of radiology. All right, so I'm gonna grab my spine model. We can see here on our spine that we've got the top part of the neck, or the top part of the spine is going to be the cervical spine, that's the neck. You've got the middle part of your spine, that's the thoracic, and then the lower part is going to be the lumbar spine. The main areas of the spine are your vertebral bodies. Those are those hard bony areas of the spine. And in between each of those vertebral bodies is what's called a disc. That disc acts as a shock absorber between each of those vertebral bones. That allows the spine to move. And on the back, we see different nerve endings that are exiting the spine. And we're gonna look here in a minute at another image, but when that disc herniates, it's like a jelly donut. When that jelly comes out of the donut and pinches on one of those nerve endings, it causes pain. And it causes something called radicular pain that we'll talk a lot about here in a minute. We also have at the bottom of the spine, the sacrum and the iliac. Where that part connects is called the SI joint. That part can also get inflamed, it can get injured. There are different areas of the brain. And each area of the brain controls a different, whether it's a cognitive function or a physical function. So those effects can be very different depending on which area of the brain is injured. So you'll see this image on your screen that shows the different areas of the brain and the different effects that those areas of the brain, when injured, can have on the body. For instance, if a certain area of the brain is impacted and injured, it can have issues with personality. It can cause somebody to be very irritable or forgetful. A different area of the brain can cause somebody to have balance issues or blurred vision or changes in smell or changes in the ability to hear. Those things are all affected by different trauma that's done to the brain. So let's shift to talk about radiology. And this is a hot topic in personal injury cases, both from the plaintiff side to show the objective signs of injury, but it's commonly something the defense is trying to use to their advantage to show, hey, there's no traumatic injury, or hey, there's evidence here that this is something that's been there long before the impact. So if we look at this image on your screen, you'll see an image of a banana. And what I love about this example is it shows the different types of images that are done and what can be seen. So you'll see first the image of the banana, then you'll see an X-ray that really doesn't show us a whole lot of what's going on. The CT scan shows a little bit more, but the MRI shows us a lot more inside the banana. This is an image of the actual spine. You'll see the differences in what we can see here. This is incredibly important because a lot of times what we hear from the defense is, well, they did X-rays at the ER and there was nothing wrong. The X-ray showed there was no injury. Well, as you can see on your screen from the different types of imaging that's done, an X-ray does not show the discs. All the X-ray is showing you, because it's a great tool for diagnosing broken bones, is those vertebral bodies that we talked about earlier, those hard bony areas of the spine. It's not going to show you any ligament damage, and it's certainly not going to show you whether or not one of those discs is bulging or herniating. All it's going to show you are those vertebral bodies. A CT scan will show you a little bit more, but still is not going to show those discs. It's the MRI that is the gold standard for being able to diagnose a disc herniation or a disc injury. And those are not commonly done at the ER. But oftentimes we hear from the defense, well, the ER showed no injury, so they must not have been injured. Understanding the distinctions between the different types of radiology makes all the difference in the world in being able to push back on that false narrative. Brain imaging is a whole nother animal. The problem with brain imaging, as you can see here, an X-ray is only going to show if there's a break in the skull. Oftentimes with mild traumatic brain injuries, what we're seeing are these breaks in the neural pathways of the brain, and those are incredibly difficult to see in any type of radiological film. X-rays are only going to see the breaks in the skull, but even a CT scan is not going to show very much either, as you can see. And even in an MRI, that's still only showing really the surface level of the brain. There's new types of studies that are being utilized more and more called diffusal tensile imaging, or DTI, MRI with DTI, that will help identify these breaks in the neural pathways. But radiology, when it comes to the brain, is one of the least effective tools in diagnosing mild traumatic brain injuries. So again, understanding imaging, not just what it can be used for, but also what it can't be used for, is incredibly helpful in pushing forward the argument and advocating for our clients on what their injuries are. For instance, in a traumatic brain injury case, there are other ways, which we'll talk about here in a little bit, other ways to diagnose that injury, where an MRI is potentially completely clean, but other objective signs, other objective tests show clearly that individual has suffered from a traumatic brain injury. Let's talk about the specific injuries, the testing, and the procedures that are done. Let's start with injuries. What are the common injuries that we see in our personal injury cases? A disc abnormality is something that we should not be seeing in a healthy disc. So a normal disc is well contained within that disc space. I made the analogy earlier about a jelly donut, right? So a normal disc is a jelly donut that has all of the jelly still in it, and it's got a good solid shape to it. A bulging disc is when that disc starts to bulge a little bit. The donut, if you will, has not broken yet, but it's starting to push down, the spine's starting to push down, and you've got some of that, you've got almost pressure on that outside disc or outside of the donut as if it's almost going to break. One thing you've got too that you're gonna see typically is what's called a degenerative disc. And a degenerative disc is not abnormal. And a degenerative disc is something that happens as part of the aging process. You'll see oftentimes in records that an individual suffers from degenerative disc disease. Defendants and defense attorneys and defense experts love the term degenerative disc disease because it sounds terrible. But the truth of degenerative disc disease, it's a normal part of the aging process. As you get older, that disc starts to lose water. And as that happens, it starts to degenerate and get smaller. That disc space gets more narrow, and that's part of the aging process. The pushback there, and what the defense hates to admit, is a degenerative disc, somebody with degenerative disc disease, is more susceptible to a trauma causing a serious issue. So the final thing I want to talk about with a disc abnormality is a disc herniation. That disc herniation means that jelly in the donut is actually shot out. That disc material has come out, and that's a herniated disc. And oftentimes what we see with herniated discs is that disc material has come out, and it's starting to pinch on the nerve endings that are coming out from the spine. And that can be incredibly painful for an individual. That's why you see individuals who've got pain in their back or their neck that can go down into their legs or their arms, that radiculopathy that we'll talk about. That's because that herniated disc material is pushing on a nerve ending. One of the things we didn't talk about is how you identify a disc. Each of the vertebral bodies are numbered. And so for a lumbar spine, that's an L, and then the vertebral number, so 4. So if you have a herniation between the 4th and 5th lumbar vertebral body, that's an L4-5 disc herniation. And you can see here on your screen, both next to the image, the MRI image, and an illustration, both from the side and from the aerial, what that herniation will look like. You can see from the image there, both on the MRI film and the illustration, that herniation has caused a pinching on the nerve roots that are coming out. That disc material has come out of that disc, and that's that disc herniation that you can see both from the side angle and from overhead. This image on your screen shows it from the cervical spine. We've talked a lot about the lumbar spine. Obviously the cervical spine just as susceptible to an injury, whether in a fall from coming down and the head going forward and going back, or the same type of motion in an automobile collision. You can see on the MRI and on the illustration where those herniations are located and how that disc material has come out of the disc and is now pushing on those nerve roots. And that's what causes the individual, that's what causes our clients to experience that pain. The next image on your screen is incredibly important. This is what's called a dermatomal map. What's fascinating about a dermatomal map is you can go down the area of the spine where the herniated disc is. So if it's a C3-4 herniation, you can find that area on the dermatomal map and track it down to what areas of the arm into which fingers that individual is going to be suffering from radicular pain. And radicular pain, or radiculopathy, or radiating pain, is pain that stems from either the neck or the mid-back or the low back and goes into the extremities, whether the arms or the legs or down the thigh. And why this is so important is because you can take the objective findings of the MRI and directly tie them to the subjective findings of what our patient or what our client, is complaining of, and tie that case together. For instance, one of the questions I always have my pre-suit team ask our new clients is, are you having any pain that's radiating down your arms or radiating down your legs? Does it ever feel like there's pins or needles in your hands or in your feet? Does it ever feel like any of your extremities, your hands or your feet, are falling asleep? Because that's a sign of radiculopathy, a really important symptom that will help the doctor understand there may be a disc herniation here. But if we don't explain to our clients why that's important, they may never mention it to their doctor. And their doctor may just ask them, hey, do you have any radiating pain? And they're thinking, well, I don't have any radiating pain. No, nothing is radiating. But not understanding that question also means, are you having any numbness or tingling in your hands or feet? And so talking that through with the client to understand exactly what their pain complaints are. Or in that pre-suit conversation, in one of those initial conversations, to ask them, hey, have you noticed you're having any sort of brain fog or memory issues or balance issues or smell issues, right? That's an odd symptom from a trauma, that their sense of smell can be different. They may not think twice about it. And then all of a sudden when they're asked that question, they say, actually the other day, a couple hours after the crash, I did notice that my sense of smell was weird. I just didn't put two and two together. Part of this job is about putting the pieces together to be able to tell the jury exactly why everything makes sense. Because when they go back to deliberations, they're going to be looking at the MRI reports, they're going to be looking at the medical records, they're going to be taking into account what our client testified to, and they're going to be asking themselves, does all of this make sense? So what we want to be able to convey to a jury or a defense lawyer or a defense expert is why everything connects. When the client's got a C3-4 herniation and we look at the dermatomal map and the radiating pain goes in the exact area that they've been complaining about since the very beginning, that makes it make sense. That helps explain to a jury, look, we've got a traumatic finding, we've got an abnormal disc, a herniated disc in the cervical spine in the neck, and we've got radiating pain complaints that correspond with what you would expect to see from the dermatomal map based on where that nerve root is coming off the neck. Being able to explain that to a jury helps them go back and be armed in that deliberation room to advocate to their fellow jurors for you to help get the compensation your client needs and deserves. So the other part of the spine that we see often get injured is the facet joint. And I'm going to take my spine model here again. And this is a very difficult part of the spine to see. What we've got on the back of these vertebral bodies are what are called facet joints. These are very small little areas in the back of the spine where each of the vertebral bodies overlaps one another. It allows for that mobility. The problem with facet joints, as you could see from the spine models, they're incredibly small. And because they're so small, they're almost impossible to diagnose from an MRI. There are other tools that doctors can utilize to be able to diagnose those injuries. But what we commonly see are, whether it's defense lawyers or defense experts or even other plaintiff lawyers that may have handled a case before us, is they'll say, well, we just don't think you've got a very big case because the MRI was clean. You had no herniated discs or bulging discs. Facet injuries can be incredibly serious and require lifelong care, yet the MRI will be completely negative. So it's important to understand exactly what a facet injury is and what the long-term effects are. That facet joint is that small joint in the back of the spine that goes all the way up. There's a facet joint at every level. And if that area is injured, there are other diagnostic tools that doctors will utilize to diagnose that condition. We talked about the areas of the brain that can be injured. Why this is so important in understanding the effects that an injured brain can have, the effects of a traumatic brain injury, are because the radiology, the MRIs, will most often be negative unless there's some sort of brain bleed or incredibly traumatic major brain injury. But mild traumatic brain injuries can cause lifelong effects and can be very serious, but yet have no MRI findings. The reason why it's so important that a lawyer really understands all of the potential symptoms of a brain injury is because oftentimes we're the ones engaging with the client and asking a lot of those detailed questions and are one of the first ones to highlight to them, you may have something more serious going on here with your brain than even you realize. For instance, a lot of times clients will tell us, for whatever reason, my wife's been telling me lately I'm a lot quicker to get mad. I've got a much shorter fuse than I normally have. Or they're telling me I'm a lot more forgetful than I normally am. Those are red flags to be able to identify this is an individual who may benefit from seeing a neurologist. Also, if an individual starts telling you, for whatever reason, I've been a lot harder to stay balanced. I've been tripping more since the crash. Or I've heard a ringing in my ear, or my sense of smell has changed. These sort of things help us as lawyers be able to communicate to our clients, you were in a serious crash and you're telling me about things that oftentimes are associated with a traumatic brain injury. Let's make sure you've got the resources available for you to get a diagnosis one way or another. But being able to understand the symptoms, those signs of something like a traumatic brain injury, helps us to be able to guide those clients to get the treatment that they need. Let's talk about testing. Let's talk about the different ways that doctors can diagnose different injuries with our clients. One of the big things that we see are diagnostic injections. We think about injections as being treatment-based. Somebody gets a shot to help relieve the pain that they're in. The reality, though, is there's a lot of injections that are more diagnostic. For instance, one of the injections that doctors often use is something called a medial branch block, or a facet injection. That's diagnosing what I talked about earlier, those facet injuries that are incredibly challenging to diagnose on an MRI. Doctors will utilize these diagnostic injections of facet blocks or medial branch blocks in order to diagnose these injuries. What they're doing is, once they believe that that may be the cause or the pain generator in someone's spine, they'll use a numbing agent at that facet joint. If the patient gets significant relief for several days, that indicates to the doctor they've got the right area and they've diagnosed that injury. Those diagnostic injections are essential to being able to diagnose those facet injuries because MRIs are just not a great tool for it. Once the doctor has been able to diagnose that facet injury with those medial branch blocks or facet blocks, they now know the next course of action for treatment, which is typically something called a rhizotomy or radiofrequency ablation, which we'll talk about here in a bit. One of the tools that doctors will use to diagnose a herniated disc is something called an epidural steroid injection. An epidural steroid injection is an injection into the disc where it's going to numb the area where that herniation is. If the patient gets relief from that injection, the doctor knows not only is there a herniated disc there, but that herniated disc is the cause of that individual's pain. And now they can confidently move on to more invasive treatment, knowing that that invasive treatment is very likely to cure that patient's problem. They also can do SI joint injections. We talked about when we were talking about anatomy, the sacrum and the iliac and where they connect. The SI joint, similar to the facet joint, is very difficult to diagnose on an MRI. And so doctors will use these SI joint injections, again, both therapeutically to help give the patient some relief, but also to diagnose that injury as being the one that's causing their pain. So there's EMG testing that helps to diagnose radicular pain. They can test the waves going to the muscles and see if they can identify if there's any radicular pain that's coming from there. One of the things about this test is when it's positive, it's clearly positive, but a negative just means that that nerve wasn't firing at that moment. So doctors never will rule out radiculopathy just with a negative EMG test. There's also TBI testing. We talked about why traumatic brain injuries are not commonly diagnosed through MRI. There are other tests that are utilized to help diagnose a traumatic brain injury. Nystagmus tests are tracking eye movement. Oftentimes an individual who's got a traumatic brain injury will have abnormal eye movement. This test is a great test to be able to see how the eyes are tracking and help these doctors to diagnose whether or not an individual is suffering from a traumatic brain injury. There's also balance testing. I showed you earlier the different types of signs or symptoms an individual may be suffering from who's had a mild traumatic brain injury. One of those are balance issues. So balance testing is one of those objective tests that can help diagnose somebody who's suffering from a traumatic brain injury. There's also EEG testing that helps to see the brain waves to see if there's any abnormal findings there. Let's talk about the procedures that we often see in our cases. One of the procedures for facet injuries is a radiofrequency ablation, or a rhizotomy. The radiofrequency ablation is a procedure that they'll do once they've diagnosed that facet being injured. And the doctor's done that by doing that medial branch block or facet block, where they numbed that facet joint, and our client got good relief from it, although temporary relief. The facet radiofrequency ablation is the more permanent fix. And what they're doing is they're putting a needle at that facet joint and they're heating the tip of that needle to burn that nerve ending. Once that nerve ending is burned, our client will typically get about 6 to 12 months of relief. But unfortunately, that nerve ending will regrow, causing the pain to come back, which means our client is going to have to get that procedure every year, likely for their life expectancy. The other type of procedure we typically see is a fusion surgery. That's typically done to help treat a herniated disc and is done after they've diagnosed that herniated disc as being the pain generator through that epidural steroid injection we talked about earlier. What a fusion surgery is doing is it's taking out that damaged disc. It's actually removing all of that disc material, shaving down the areas of the vertebral bodies where that disc was, and it's putting in spacers where that disc was, and then a cage and screws to permanently fuse that area of the spine. It'll relieve that radicular pain because that damaged disc is no longer pushing on that nerve ending, but it'll decrease that mobility because there's no more disc there. So while it can relieve that radicular pain, the sacrifice that our client will have to make is that they're going to lose mobility in that region, and because that area is fused, the area above it and below it will have more pressure on it through the course of that individual's life. That's called adjacent segmental disease. The result of that is that our client typically will require a subsequent fusion down the road at the area above or below where that fusion took place. Another procedure to treat a herniated disc is a disc replacement surgery. A disc replacement surgery is where the surgeon will go in and remove that damaged disc material, similar to a fusion, and instead of putting a spacer and fusing that area of the spine, they'll actually put an artificial disc there. That artificial disc will allow allow the patient to still have some of that mobility while treating that radicular pain that stemmed from that herniated disc. Another treatment that doctors can utilize to help treat back pain or neck pain is something called a spinal cord stimulator or an intrathecal pump. Those are two different types of things, but a similar procedure. The spinal cord stimulator is where there are leads that will go up the spine, and then they'll land on the area of the spine that's giving that patient problems, giving them pain, and those leads will run back down towards a battery pack that is implanted in typically around the belt line of our client. That spinal cord stimulator will send signals and try to scramble the signals to the brain so that the brain's not receiving those pain complaints. So it's really a Band-Aid. It's not treating the underlying issue, but it's helping to relieve their pain complaints. The other tool they sometimes will use is an intrathecal pump. Similar type of procedure where there's the pump is actually implanted under the skin right around where their belt is, and that's pumping in pain medication, again, not to treat the actual injury, but to help mask that pain. We've talked about the anatomy in films. We've talked about the injuries, the testing and the procedures that we often see in our clients' cases. Let's talk about some of those common defense arguments. One of the common defense arguments that we see is there's not a lot of property damage, right? There's not a big crash, there's no airbag deployment, there's no way your client could have gotten as hurt as they say they were. There's a lot of pushback. There's a lot of arguments that can be made to advocate for our client. Because quite frankly, the medical is what it is. We can clearly show they've been injured and they're treating. So how do we push back when we know the defense is going to throw up that image where our client's car is not badly damaged? An example I always love to use at trial is to actually take my chair and bring it around in front of the jury and sit down in it and tell the jurors, if we took a lineman from whatever NFL team for whatever city I'm in at that time, and say if that NFL lineman went full steam ahead into the back of this chair and hit me as hard as they could, there's probably not a single person on that jury that wouldn't believe that I got a serious injury from that impact. But if we turn that chair around, there's likely not going to be a big dent in that chair. The chair is probably not going to be broken. It may have some scratches from where they made contact, but the chair is likely to still be intact. Now, especially imagine if I'm strapped in, if I'm buckled into that chair and hit that hard, and how much it's going to throw me. Especially if that chair becomes stabilized, becomes implanted in the ground. That jerking motion clearly would be enough force to cause me an injury. But the impact would not cause the type of catastrophic failure to that chair that you might expect from the types of injuries I'd be claiming. Understanding the medicine helps to drive the value of the case and drive the damages in a case, because we need to be able to explain to a jury what the injury is and why it's significant. If we can't grasp these medical concepts, we can't ever imagine that we're going to be able to get a jury to grasp them. We as attorneys live these cases and we live these injuries with our clients. Jurors are spending 1 to 5 days, maybe 2 weeks, being immersed in this case and getting a crash course in the medicine. To be able to explain to a juror these complicated medical topics in a way that they'll understand it, and in a way that they'll be able to attach damages to it, monetary damages to it, we have to have such a grasp of it in such an extreme degree to be able to take those concepts and make them digestible for a jury. Because a jury is going to take what they know about our client's injuries and try to assign monetary compensation for it. Do we have an individual who's more susceptible to injury? This is where we can use the defense's own arguments against them. Time and time and time again, they're going to say, well, your client had degenerative disc disease. They've got degenerative conditions in their spine. They've got pre-existing issues. They've been complaining about their neck for years. Well, now you can use those arguments against them. Well, the property damage may not be significant. But had my client not had degenerative disc disease, had they not had chronic issues going back several years, they likely would not have been as susceptible to being as hurt as they are, with the damage being what it is. Because my client's got a history of back injuries or a history of neck complaints, or because they've got a degenerative or arthritic spine, this type of force was enough to be the straw that broke the camel's back. If it had been an 18-year-old who was in perfect health, maybe they don't get as hurt in this impact. But we've got an individual, as you've pointed out, defense expert, who's got a degenerative spine, which means they're more susceptible to trauma causing a significant injury. It's all about context. It's all about taking all of the evidence that we have and putting that into context to telling our client's story. Because ultimately, our client's story is the truth. They were involved in a crash because of no fault of their own, or they fell at somebody else's premises because of that individual or that company's negligence, and that's what caused their injuries, and that's what caused the treatment that had to occur all the way up into the point of trial or even long into the future of their life. That context matters. Another argument that defense experts or defense lawyers love to make is that the condition is degenerative, that they've got this degenerative disc disease and that this is a chronic, long-standing issue. It's important to point out the difference between something being asymptomatic and symptomatic. In other words, just because somebody's got a degenerative condition doesn't mean they were suffering from it. Just because somebody's got degenerative disc disease or arthritis in their spine doesn't mean they've got a history of pain complaints. Sometimes the trauma of the crash can cause an asymptomatic degenerative condition to become symptomatic. That's where the timeline matters. Prior to this crash, how often were they treating for that condition? Following the crash, how often were they treating from that condition? Degeneration only matters in the scheme of the overarching picture. Did that degenerative condition, did that arthritic condition, was that caused to be symptomatic because of this crash? Somebody can have long-standing chronic degenerative conditions and not have pain from it. And then they're involved in a crash and now the pain's begun. So what was really the cause of the pain? It was the event, it was the incident that forms the basis of that claim. With TBI injuries, we often hear a few things. One, the MRI is clean, and we talked about that. Show them the findings on the nystagmus test. Show them the findings on the balance test. The other thing that we often hear is that most mild traumatic brain injuries get better over time. The vast majority of mild traumatic brain injury symptoms will get better over the course of 6 to 12 months. One thing that's important to keep in mind when those arguments start to happen is pointing that defense lawyer or that adjuster or that defense expert is pointing them to the research, pointing them to the journal articles that talk about the long-term effects of individuals who have suffered mild traumatic brain injuries. For example, there was a study that came out that talked about how individuals with mild traumatic brain injuries were twice as likely to suffer from dementia or Alzheimer's in their older age. So again, putting things into context. This may just be a mild traumatic brain injury to the defense lawyer and the insurance adjuster that got better in a few months. But it's our job to advocate that this is not a one and done type injury. This is the type of injury that can cause long-standing and lifelong effects beyond what we can even know about today. We always hear priors. Defense lawyers, adjusters, they all like to talk about prior injuries. Well, this individual had a prior car crash 3 years before this. This wasn't all caused from this crash. Priors can sometimes be one of our best tools to advocate for our clients. If our client 2 years before this crash had a prior MRI, and we're able to take that prior MRI and show it next to the current MRI and point to the clear differences, the new herniations, or the herniation that got worse, now we have a before and an after picture in a case where it can't be disputed what this crash caused. The other thing is taking the subjective complaints from those priors. Do those priors talk about a 3 or 4 out of 10 pain, and now we're at a 6 or a 7? Do those priors talk about an individual who had no radiating pain or no radiculopathy, and now we've got those radiating symptoms? We've got that radiculopathy. We can use those before and after pictures to help advocate for our clients so that we can point out exactly what's new. What did this crash cause? And take what is typically a negative in our case and flip it to become one of the positive things in our case to help show clearly what this incident caused. Another argument we hear about is that our client is older. They've got a long-standing history of other medical conditions, so their pain and suffering is pretty limited. I always push back with this and talk about how I've got a client who's in their 80s, who's got a long-standing history of chronic health conditions. And what that means is that their gas tank was running pretty close to empty. They had about 10 or 20% left in the tank. And this crash took that 10% out of their tank to bring it to almost empty. You take a healthy 18 or 19-year-old with 100 or 90% left in their tank and take that same 10%, it doesn't have near the impact that it had on my elderly client. Showing the defense that just because somebody's got a history of pain and other chronic unrelated conditions, it doesn't devalue the claim. but actually adds value to the claim. They deserve compensation just as anybody else would, and are now being forced to live their golden ages, to live the last years of their life in even more pain and discomfort than they were already having to deal with. Most jurisdictions have a jury instruction that tells the jury that if this injury aggravated or exacerbated a pre-existing condition, that the defense has got to compensate that individual as if it caused a brand new condition. In other words, if there was something that was prior, that was already there, if there was a pre-existing condition that was already there, but this exacerbated or aggravated it and made it that much worse, that the jury's left with one of two things: to figure out what percentage it was made worse, or if they can't do that, to compensate that plaintiff fully as if it were a brand new injury. And so utilizing those jury instructions in your jurisdiction with defense lawyers or adjusters can help point out the flaws in their arguments. Another common argument we hear: there were no MRI findings. The MRI is clean. There are no bulges. There are no herniations. What's the injury they're treating for? What's the diagnosis for that condition? Is it a facet injury? If it is, point them to the diagnostic injections, because that's the gold standard for diagnosing that injury. If it's a brain injury, push them back to the nystagmus test or the other tests that were utilized by the neurologist to help diagnose that brain injury. One of the most frustrating arguments I hear is when defense lawyers tell me, or adjusters say, well, the x-rays, the CTs, they were normal at the ER. Well, of course they were normal. We're not alleging a broken bone. We're not saying there was a fractured vertebral body or a broken arm. We're saying they've got a facet injury, or we're saying they've got a herniated disc. Those things would not be diagnosed in the x-rays that were done at the ER. That's not what they're for. The ER is the triage. The ER is to make sure nobody's going to die or bleed out and then refer them off to a specialist. So the notion that the imaging was clean at the ER is simply a red herring. We often hear defense lawyers and adjusters make the argument, well, there's gaps in treatment, or they stopped treating. Well, if we take a step back and think about how someone with these types of injuries would live their life, the reality is nobody wants to go to doctor's appointments every week. Nobody wants to be getting injections over and over again or getting surgery. A normal person would get to a point where they would say, okay, this is my new normal. Let me see if I can return to my life and live my life as I did before and try to push through the pain. And that's what happened here. They'd gotten an injection, or they were recommended for an injection, or they were recommended for a surgery, and they took a step back, as a normal person would, and said, let me live my life without having to undergo this type of procedure and see if I can do it. And as each month went by, and it became harder and harder and harder to sustain their normal life with that pain, they finally realized the only way they were going to be able to live their life as they did before is to undergo that procedure, undergo that injection. And so it's not a gap in treatment. It's somebody who's trying to live their life without having to undergo serious operations, serious injections, but they got to the point where they no longer could. The other thing too is explaining to them in the very beginning why consistent treatment matters. Their treatment, the medical records, that's the evidence of injury. That's the evidence of pain and suffering. If they're not treating, it's going to tell the defense and a potential jury they must not be that hurt. It's our job to counsel them at the very beginning of their case so they know the landmines they could potentially step into. That if they are hurting, it's important that they stay consistent with treatment. That if their doctors are making recommendations for them to get better, that they follow through with those recommendations, both so that they can get the treatment they need and get better, which is the ultimate goal, but also to stop the defense from making those arguments that we know they're going to make. Let's not give them that ammunition. Let's cut that off before it ever starts. And we do that by educating the client from the onset. Understanding the medical, it also is so important in helping to craft a litigation strategy. And what I mean by that is knowing the extent of their injuries, the types of their injuries, is going to help dictate the way we litigate the case. It may change the type of experts we may need. For instance, if somebody's undergoing a radiofrequency ablation, what we know both from the doctors and the literature is that a radiofrequency ablation is going to have to be repeated every 6 to 12 months. So that litigation strategy is going to require a life care planning expert to be able to put together a plan that's going to be able to show the defense and eventually a jury how much that treatment is going to cost over the course of their lifetime. Also, we talked about fusion surgeries. Understanding how serious a fusion surgery is for an individual, and also understanding that adjacent segmental disease concept, which means typically after about 20 years, they're going to require another fusion at the level above or below, will help shape not just the need for that life care planning expert to talk about the cost of that second surgery, but also in our consultations with the treating doctors before their deposition, to make sure that we're eliciting that testimony from that doctor about what adjacent segmental disease is and how it's going to impact our client so that we can put that evidence in front of a jury. Not understanding these concepts will prevent us from being able to make these arguments to a jury. Having a doctor, a treating doctor, testify in a deposition, they're going to answer the questions they're asked. And if we don't understand the injury, and we don't understand the impacts that injury can have on the course of our client's life, we're not going to know the types of questions that we need to ask that doctor to elicit the information that is important for a jury to understand and contextualize how this incident, how this crash, how this fall is going to forever change our client's life. Presenting these medical concepts to a jury is incredibly challenging. It's challenging because a lot of this stuff can be really boring. It can be incredibly detailed. It's often using new vocabulary, and you can see the jury's eyes getting glazed over when you start broaching into this arena. Finding a way to connect with jurors to make this stuff interesting is the difference between a verdict that's full and fair and one that just doesn't make sense. And typically that one that doesn't make sense is because the jury did not understand the medical. They didn't understand the extent of the injuries. And they didn't understand it because it wasn't put to them in a way that was both understandable and interesting. There are a few tools to get around this. There are a few tools to kind of get over this hurdle of how boring the medical can be. One is when I'm presenting testimony from a doctor about the injuries, I start with this sort of med school 101 type lecture, just like we did here today, where I'll have the doctor get off the witness stand, I'll give them a spine model, and I'll have them talk to the jury as if they're in their classroom and walk them through the different areas of the spine and those different types of injuries. If I can get them off that witness stand, that alone can help make things more interesting. The other thing that I always want to utilize is demonstratives. Anytime you can find a picture, an illustration, a video, a model to help illustrate that point, it'll help keep the jury engaged. So when I'm getting that doctor to come off the stand and talk to the jury about the medical, I'm having them use that spine model and pointing to different areas of the spine. A lot of times I'll have them sort of walk up to specific jurors as they're pointing to things to help keep that jury engaged. Another really helpful tool when we look at the procedures, the surgeries that are done, are animations. Because one of the problems with doctors testifying is they do these types of surgeries day in and day out. It's pretty sterile to them. So to have that imagery behind them as they're talking about making the incision on the neck, opening it up, taking out that disc material. If a jury can see that in an illustrated fashion, it's one, far more interesting, and two, far more powerful. Because when a doctor is just talking about these procedures, they're talking about it as if it's no big deal, because to them, it's not. One of the other tools I like to use is I like to throw up as an exhibit the waiver that our client signed before getting a certain procedure, whether it's an injection or a surgery. That waiver where they're waiving not just their rights, but they're acknowledging the risks and the side effects. They're acknowledging the potential for paralysis. They're acknowledging the fact that they may die from this procedure. And yet, even with that, they were in so much pain, they said, I get that I may be paralyzed. I get that I may die, but show me where to sign because I can't be in this kind of pain anymore. So having those tools at your disposal helps keep the jury engaged to understand the magnitude of the situation, to understand the seriousness of the injury itself, and quite frankly, just to keep them awake and engaged through these medical discussions. Because jurors oftentimes, they show up for jury duty and the reality is they're expecting, one, that it's a criminal trial, and two, that it's gonna be similar to something like Law and Order. And so once they get in and they realize, well, it's a civil trial and they're gonna have to learn all these different medical concepts, you can see that excitement kind of leave their eyes. And so making sure that we're putting up that information and that evidence in a way that keeps them engaged, whether through illustrations, whether through models and different types of demonstrative tools. If they're getting injections, having the doctor actually bring in the needles that are utilized during those injections, those types of things help the jury stay interested and help them understand why not only the injury is serious, but the procedures that our client had to undergo were serious. Early on in my career, I was given some of the best advice I think I've ever gotten when it came to being a personal injury lawyer. And that was understanding the medicine will make all the difference in the world. Not just for the ability to advocate better for your client, but also to be able to understand what they're going through. And so I immersed myself into this field and immersed myself into really understanding the different types of injuries, the different types of imaging. And it's allowed me to better connect with my clients. It's allowed me to build more trust with my clients. And it's allowed me to go toe-to-toe with whatever defense expert enters into my case, knowing that I'll never take less, I'll never devalue my client's case just because of a silly defense argument where they think they're going to use some fancy medical terminology or misrepresent what something shows in an effort to make my client's case seem like something it's not. I've become passionate about this lecture. I've become passionate about understanding what our clients are going through. And I'm confident anybody who really is able to grasp this information and grasp the different things that doctors are doing in our cases for our clients, they'll make themselves better advocates for their clients and they'll be able to see better recoveries overall for their clients.